Afternoon. Good afternoon, everyone. Welcome to the first meeting of our ECHO, HIV-TB ECHO. And this afternoon, I have been joined by Dr. Sivile, HIV advisor, and he will be talking about subject on the new, an overview on the Zambia Consolidated Guidelines. That's some of the key changes that have taken place. Thank you so much for joining us. I'll just do a sound check, just to make sure that I'm being heard. So I'm going to ask Chinsali, this district hospital. Chinsali, can you hear me? Good afternoon, Chinsali. Are you able to hear me? You can unmute and just speak.
Good afternoon. We are able to hear you.
Thank you very much. Bernard Chashi from Shuangandu. Thank you so much for joining us. Are you able to hear us?
Yes, Doc.
Thank you very much for joining us. We appreciate your commitment to join us. I can see there's Nyimba District Hospital. Nyimba District Hospital.
So much is
I have also seen St. Luke's College. And, I have seen the Zagris from Sinda, Eastern Province. Thank you for joining us, sir.
Memo. You may also want to unite with some.
So thank you very much, everyone, for joining us. So we will just begin our session very soon, and just to be able to interact in this particular session. Thank you very much. So thank you very much. I'm just going to invite Dr. Sivile to introduce himself and what he's going to discuss this afternoon. Dr. Sivile.
Good afternoon, network. Good afternoon, Dr. Ziambo. I'm Suilanji Sivile. I'm the National HIV Technical Advisor. Health. I'll support the running of the program. So again, we changed our consolidated guidelines for treatment and prevention of HIV in Zambia. We are going to quickly run through some of the salient features that have been revised in these new guidelines. I must say that we don't have the soft and the hard copies available. They're still undergoing the formatting process. So really the objectives of the session is to discuss the key changes that have been put in the 2022 Zambia Consolidated Guidelines for Treatment of HIV, and we'll discuss some of the rationales for these changes. So the document is not so different. There's a minor changes on the document itself. It looks very similar, but there's a map and some of the colors changed at the physical, and there's some red dots. Look quite similar. What is new? So obviously the first emphasis is for DTG, for pediatric population. We had put an amendment in the previous 2022 guidelines, but not formalized in the guidelines. So now this is a Ministry of Health HIV program policy. Secondly is DTG transition without a viral test, and we'll talk more about this. We intend to phase out efavirenz and nevirapine-based regimen from our ARVs in this country. Darunavir, agreed to use it for second line. Use of baseline Vowel. Prevention is a big issue that we want to start emphasizing more, especially for adolescents and young people. The pivirine vaginal ring has been adopted for high-risk populations, and we've added STI screening and treatment, and also some guidelines for migrant populations. This is really to start picking at these high-risk populations, what we want. So typically, we love our consolidated guidelines to, at least last time when we sat in 2020, end of 2019 to 2020, we had put a lifetime of 2 years, and that's one of the reasons why we are revising them. And the other issue is WHO did update the consolidated guidelines in July 2021, last year. So we thought of picking some of the recommendations there. But really, there's been some new local and international evidence which has prompted us to adopt. And also the epidemic has changed the last 2 years. The time we were introducing those guidelines, we were right at the expansion phase of our program, especially the treatment side. We're still looking at how do we expand. And now we think we are getting right at the top of the graph. And we have to be thinking of priorities, strategies, which have to do with the maintenance of the epidemic. There are some pending documents which will really guide to what we'll be doing this year and going forth from now. The Ministry of Health is reviewing the National Strategic Plan for Zambia 2022-2026. I'm sure soon it will be released. So there's a draft form. The WHO also has got a global health strategic plan for HIV, hepatitis B and STI. Again, it's supposed to be 2022 to 2030. That there's a draft form and there's some work. The PEPFAR program also is doing their strategic plan, which should be released soon, 2021 to 2025. I don't know if that's, but there was work had progressed. Now, where are we in the epidemic? Just to show everybody knows, I think we've explained this, that it's difficult where we are to say where we've reached 95 or that kind of a thing in terms of the cascade, because we are not so sure in terms of the estimates. I'm sure Dr. Ziambo, they've put a session next week when we spend a little bit more time to look at these numbers, our performance and so on. But really, I just wanted to show that if you look at the last 5 years, our treatment curve has really been improving. 2017, we were at 850. About October 2021, we are about 101,196,000 people on treatment. This is MOH data, might be a bit different from the PEPFAR, but not so, the variation is so minimal. It's only that MOH picks some other facilities that PEP doesn't. The graph at the bottom is worrying. Still looks like we are off the mark in terms of epidemic control. We still have those high infections, the blue line. We want it to be below the red line and both reducing, so that gap isn't good. And so while the treatment coverage seems to be steadily increasing, and if you look at that graph, we might be going towards the peak where it's getting steady. New infections on the blue graph seemingly have not been going down, they are steady, and you see a bump there where somehow even went slightly up. Yeah, so these are the epidemiological changes of the pandemic that we need to be paying attention to as we move forward. So, as you know, we've recommended the use of dolutegravir regimens for children above 3 kgs and 4 weeks. And we know because DTG has got excellent viral outcomes, high genetic barrier, broad therapeutic window, and relatively few drug interactions compared to the PIs that we've been using. And the most important thing there is the issue of tolerance. Yeah, we know it's once a day, and the test issue in terms of compared to the PI. So the evidence is solid. Actually, I was looking at there was a newer paper apart from this now, which actually does show comparing head to head that the there. So the implementation has been a phased approach starting somewhere in September last year. And this is just showing the dosing charts. I'll not go on, but it's a 1 tablet that you can give, 4 tablet, half a tablet, and so on. And these are the numbers. Phase 1 is ongoing. Phase 2 should be starting in February, and we have received some more consignment of drugs. Jambo.
All right, thank you very much. So far, Dr. Sivile, I think doing a very good job. Now we want to invite the network to participate in this activity today. So I'm going to share the 4 questions and inviting you to just pick out which one is the best answer. So we have a question here and saying, according to the 2022 Zambia Consolidated Guidelines, which of the following is true concerning viral load testing, transition people living with HIV from TLE to TLD? And so we need to pick which one of these is true. It says viral load testing is required to avoid mono switching of ARVs. Viral load testing is required because the drug resistance to NRTs is common in Zambia. Viral load testing is not required because a failing NRT backbone is equally equally effective when used with DTG. The viral load testing is not required because because of resistance to TDF is rare. So there's these options here. I think we should have had 4 options. The E wasn't supposed to be an option here. Just need to have 4 options, A, B, C, and D. And of these, which one is true? So I know there's quite a range here. Most people have voted. We have about 41% of votes. Yeah, out of 500 people. we are expecting people to participate actively so that we see how we are doing. And most people think A is true, some think C is true, followed by people who think C is true. I know most of us have not had an opportunity to look at the revised guidelines, so you will be spared if you don't get this one correct. So I'll end the poll now, just after a few more seconds. Okay, thank you very much everyone for participating. And this is how we are fared. As I'll just share the results. So most people think A is correct. Some think C is correct. A few more think B, and others think all of the above are correct. So end the poll, and let's hear from Dr. Sivile.
Yeah, thanks, Dr. Ziambo, and we will get back to the poll after the presentation. So transitioning to DTG without a vowel testing is a new recommendation we have in the guidelines. And this is based on a local trial that we did here at UTH. I'm sure most of us here were part of the designing and the implementation of this trial, the Bison trial. And there's also a trial which was done in Cameroon, the Nadia trial. Both of these show evidence that this is the way to go, and WHO has moved. Hasn't yet really recommended, but the thought is that they'll move that direction. So Zambia recommends that the transition from TLD to TLD is without a vowel load test. Obviously, you can see that we've really gained some mileage in terms of transitioning our patients to DTG. We are right at 93% as of September 2021, but still, the few that are still on TLE, when we are transitioning, right now you don't need a vowel load. Really, we would have loved to have this evidence earlier. We think the transitioning would have been much smoother. Yeah. So we know that the recycling of the NRTI backbone is actually efficacious. There's now no doubt about that. It's only that people are not so sure of the longevity, how long that effectiveness lasts, but there's strong evidence from multiple random controlled trials. So this is just one of them, the Nadia trial. We have our data from the Vicent, but because of the embargoing issue and so on, we want to present that in a major conference. So that I haven't really shared the numbers. But we can see here that the conclusion from the Nadia trial is that dolutegravir in combination with NRTI was efficacious in treating patients with HIV-1 infection, including those with existing NRTI resistance. The NRTI were predicted to have. So really, if someone is on TDF, efavirenz, TDF and lamivudine, and efavirenz, and they felt that indeed you don't know that they are failing or they are failing, if you switch them to TDF, again, lamivudine and dolutegravir, that combination is efficacious. So this will have quite a lot of interesting implications in how we see our patients, even in routine clinical practice. But now the recommendation is strictly on transitioning patients. Other scenarios are probably, we might have to discuss those things, but it's good data. There are some previous trials, actually I must mention, about 3 other big trials, which showed similar findings, including those which used PI, like the NS trial. So this is evidence that people have known for quite.
Thank you so much. Another opportunity for the participants to take part in this session. So we are going to share with you the second set of 4 questions. Then you can simply pick which one is the correct answer. So this particular one, we are also saying, according to the 2022 Consolidated Guidelines, which of the following is not true? Which of the following is not true concerning the use of efavirenz? Efavirenz should not be, efavirenz should not be used except in exceptional circumstances. Efavirenz should not be used except in exceptional circumstances. B, patients initiating ART can be offered efavirenz. C, patients with side effects to DTG can be prescribed efavirenz. Patients who refuse to be transitioned to DTG must be continued on efavirenz with continuous counseling. Which one of the following is not true according to the latest 2022 Consolidated Guidelines for treatment and prevention of HIV? I see already people have started polling. We are inviting you all to participate. Please do poll, make your polls. Is it A, is it B, is it C, or is it D? Most people so far have picked B. There seems to be quite
Competition.
yes, a
A and
competition between A and B, and only 84 out of 584 have actually polled. We're inviting you to just kindly take part and participate. Okay, you have 10 more seconds before we can
Still
end the
84.
call. Yeah. Maybe it was a tricky question.
Yeah, but that's sometimes sorry to bring you back to classroom where they are accept and so on, not kind of MCQ. But I love it that way. I hope you have a bit of some academic.
All right, so I'll end the poll with only about 14% participation.
Yeah.
Okay, so can move on to the
Maybe it's us.
Satonda, are we still connected? Great, thanks. All right, I think we can move on to the next slide.
Thanks, Dr. Ziambo. Yeah, so this is the results from the HIV drug resistance survey that we did in Zambia here. I think this has been presented here at several occasions by Professor Mlenga. We did this in 2019. Over 2,000 patients were recruited. And so the findings are really representative of our program in Zambia. I'm sure most of us have seen the detailed presentation, but really the biggest take-home message from that surveillance is resistance, primary resistance. This is resistance pre-treatment, before you put someone on ARVs, was at 16.2%, efavirenz and nevirapine. And this is way above the 10% recommendation by WHO and other bodies that once you have resistance to that particular drug, over 10% to remove it from circulation, as it were. So the evidence is local and strong evidence, good, strong national representative data. We had facilities participating there, facilities like I myself was doing this study from Luwingu, so rural facilities, Luwingu, Kasama, Popabot, the whole country. And this is what we found. Obviously, what we didn't do in these studies to check, metabolites, whether these people were actually not on treatment or on treatment, but even then, the 16.2% is really, really big. So because of that, no new patient should be initiated until. So this is a strong recommendation because the evidence is strong, except in exceptional situations. And those are some of the exceptional situations we're discussing, like maybe somebody, you see this, some of this in the guidelines once you have them. Maybe somebody has a side effect they can't tolerate, or TG, that kind of a thing. But things like someone who's a diabetic, who's obese, and so on, still not accepted. You have to transition, especially the new patients. Obviously, there are some patient preference, especially transitioning. There are patients who say, well, I've been taking a tripla, and they call it tripla. Yes, I've been taking the tripla from, I don't know, 2008. I'm fine with it. I don't want to change anything. We respect patient opinions, but we say you have to continue counseling them. So we expect that by the end of this year, we should have at least less than 2.5% of our population to be on theory. That's less than what we'd like is to have 0 on theory by the end of the year. So that's a strong recommendation. Second line treatment. This is not a new recommendation. It was there in 2022, and the reasons are obvious. That we can use dolutegravir 800 darunavir for patients that are in second line where applicable, especially those who failed DTG. Now that we have a lot of patients who are on DTG, and sooner or later some will be failing. The reason is simple. Darunavir is once a day drug, a bit more tolerable, better safety. I mean, like in terms of lipid profiles and so on, it's much better than our drug, other drugs that we're using, and also supply issues as well. There's a worry for third line use. Obviously, there are newer drugs that we anticipate to come on the market as time progresses. Those who will be failing these drugs and going in the. This is a straightforward recommendation. Though I must state that we still want most of the patients in second line to be on DTG, those who had failed non-DTG based regimen. And this is just an algorithm on how you select. Still, lopinavir is our first choice simply because of the high rates of TB, and those that are taking anti-TB therapy cannot be given darunavir. So I must mention there is also look at our survey, HIV drug resistance survey for both pediatrics and adults. PI mutations were very uncommon, even those that fail. So we think we cannot wait for our third line cohort to grow to start with better drugs. It shows that some of these drugs like DTG and just even their tripla is a very good drug that I think people are not using. So we've also recommended baseline Vowel test. Now, the reason is really to track our silent transfers. Right now, the data that we have from the recent testing shows that about 30% of the new patients are actually suspected to be silent transfer. And also, baseline Vowel is used for recent testing. And it's supposed to be quality assurance. There, quality assurance for the test. We've had some issues, not big ones, where there've been a few scare or false positives and things like that. But there's also a clinical utility for these recommendations. So the samples will be collected as part of the safety labs. What we mean is that as someone is diagnosed with HIV. The time you are starting treatment, you also collect this baseline viral load test. And as you are collecting the creatinines, the FBC, and so on. But the patient should be started on treatment. The test and treat still stands before the results are out. So ART initiation should not be based on viral load. A few implementation issues. Those who, there's some lab work that goes on to find those who have a negative or non-amplifying HIV baseline viral load test, like it's suppressed. So there's a lab algorithm I would have loved to share this time. But at the end of that, it will be established whether this person has HIV infection or they don't have, whether you get to have a PCR, or I mean, a qualitative PCR, like a DBS, the way we do. So there will be patients who at baseline will be found to be the so-called silent transfers, that they are positive but suppressed. Likely those are silent transfers, and a few occasions they could be what you call elite controllers. Those patients, really, their results will be taken back to the facility. Facilities will be given some instructions. Let's hope you find those in the guidelines, how to counsel the patients. One of the primary things is to call. Once you counsel the patient, it turns out that this is a silent transfer. You have to speak to the facilities where they are coming from so that the data is reconciled, that this patient is actually turns out as opposed to lost to fallout. So that there's a negative there and you have a positive. We don't have these, we're not testing the same people in the program. So that is very important. That's the action we are asking for the facilities. I hope that we should have a session just about this next time with the platform. But there will be those who will be, maybe there was something wrong with the test, that will be handled by a higher level at national and PhD level. So those tests will not be released to by the lab. So if the lab people, what we want is that we've changed the requisition forms. The requisition form should indicate that this is the baseline viral. And the lab people will be dealing with the baseline viral load and the normal viral load, the routine viral load differently, so that when they do identify that there's a suppressed baseline viral load, further test is done, and whatever the outcome, they'll also have SOPs where there are those results which should be returned to the facility, and the results which should really be sent to the national level, so that there's some surveillance of quality and so on. So this is very important for the program. Because of that, you know, we are reaching saturations and we're getting surprised that sometimes some facilities are giving us still more people when we expect them to have next time. So I hope we'll have some time to discuss over the best in viral load. Just to mention that people have been asking for a memo, so that memo will be out before the PSC's office.
Thank you so much on that point. Satonda, could you help me with was third poll? So the third poll will look at the true and false. So data has shown that new HIV infection are highest among the 18 to 24 years old, and females are more than 10 times affected than males. So, Satonda? Okay, great. So I'm sure we're able to pour and we can see the question. Okay, give it a bit more. Seconds. So this one has got more
people attempting. So
Over
it was
60%.
deliberate. The other one where we have 14% people attempting. It was deliberate. So the question that difficult. That should be disqualified today.
Perhaps.
Perhaps.
Thank you very much. I think we can end the poll. Just share it. All right. So yeah, but 86% think it's true. So let's go ahead to this video.
Yeah, so remember we've spoken about the graph. Really, in our program, we hear more as the NSP comes into play, and we will have some sessions on priorities, and we'll have a session maybe next week to look at the performance, the data. It looks like we haven't closed the tab. We'll see what the fear shows us, but really looks like we haven't closed the tab. We have a lot of new infections in them. And unfortunately, from the ZDHS shows that most of the infections are within that bracket, and not only from the ZDHS, from the team data. So this is pretty much a fact from different sources, including the previous year of 2016. And unfortunately, females are over 10 times more affected at age group, and we've talked about it. But now that we know where the problem is, which population in terms of new infections we've left behind, we are strongly recommending that interventions by partners that are specific for that populations are prioritized. And this is what you find in the guidelines. Things like social network testing and preventive messages must be considered, specifically designed for that age group, adolescent girls, and adolescents and young people, and specifically for adolescent girls. PrEP should be promoted for older adolescents and young people. We've seen some partners doing this, but the uptake isn't very good. We're looking at the work from one of the partners last week with Dr. Gambo. You have maybe 500 children, adolescents that are eligible, but only less than 17% or so ends up to be on PrEP. We know that it's an early intervention, but more work needs to be done. The dreams like interventions, these are very encouraged. We are advising that everybody involved in the program start moving towards that direction. And collaborative efforts with other entities such as schools, churches, and others. We know that this cannot be a fight that can be fought only by the Ministry of Health, but also other line ministries. So in districts, we involve the education, agriculture, social welfare, other line ministries, to come on the fore, because this is a big problem. And also fostering linkages for the orphan girls and to empower them and so on. And all these we require serious help from other line ministries. There's some disturbing findings from the ZDHS, those that didn't see them, didn't look at the 2018 ZDHS, such as low levels of comprehensive knowledge of HIV at 38% for 15 to 19-year-olds. So they don't know much about HIV, how to prevent and so on. And these were simple questions, how is HIV transmitted? How is it prevented and so on? Yeah. And they don't know. Only 38% of the young people know they can give you the correct answer. And this is here in Zambia. This is our evidence now where we stand. Early sexual debut, 17% of women already active at 15 years old. High levels of teen pregnancies. I think we've seen this in the media. high school dropouts, but also low condom use are only at 33% for that age group 15 to 24 when they have engaged with a non-regular partner. And the sad part about this indicator is it's actually falling compared to the 2007 ZDHS, not improving. You know, you find that they were using more condoms in 2008, that same age group compared to what we're doing now. So we have more work to do in this part of the program, prevention, especially for this. So we have some of the new interventions, innovations for prevention, like the dapivirine ring, which is just a topical microbicide containing antiretroviral drugs, the dapivirine, which is an NNRITI, class 4, so a little bit of higher resistance barrier, long-acting, can be placed every 4 weeks in the vaginal canal, and the studies show that the efficacy is around 30%, somewhere there, recommended by WHO, European Medical Association, and so on and so forth. So this, we know that it's not much, but we really need to prevent these new infections. Next slide. Yeah, so we are saying that it should be offered to women who are reluctant to use oral PrEP, but remain at high risk of HIV infection. So these are such as pregnant and breastfeeding women, a high priority. We are encouraging PrEP in that population, but there are those who are reluctant. Female sex workers, serodespondent couples, and women experiencing intimate partner violence for one reason or another. So these are the high risk individuals, the age group that might be also adolescent girls and young women. So it's really for high risk patients who cannot afford or are reluctant to take the oral PrEP for one reason or another. So just to remind everybody, critical information for the patient, that every patient should know that still oral PrEP is far much superior compared to the dapivirine ring, which is supposed to be 30% there. I've been changing this slide, but it's not changing. I don't know why. So any woman who is interested in the ring must be counseled that oral PrEP is far superior, and the ring should only be offered to women who will not be or even who should be encouraged, and if they do accept, they should also be encouraged to condom, and when they are able, they should them to oral PrEP. So indeed, there are some populations for various reasons who this intervention will be very, very useful. So concerning opportunistic infections, we know TB has been a big issue. I'll run a little bit fast. I'm noticing that I'm running out of time. So we are recommending the use of the computer-aided diagnostics. Really, this is where artificial intelligence software, often referred as CAD, can analyze the images and generate a score for the likelihood of TB. From normal up to abnormal, this score is up to 100. And all patients with an abnormal score, I think SOPs would be given what's the cutoff point, are screened positive, and they can be presumed as TB patients. But the score cannot be diagnosed as presumed. For the diagnosis, a clinician and the radiologist should read and interpret the images. So this is, you've seen some mobile x-rays and so on, some screening where you screen and say this is presumed, and you have somebody to look at that. So this has been also recommended by the WHO guidelines. Next. Same with the use of the CRP. This is an acute phase protein which shows some inflammation. So again, I know typically been using this, the ESR and so on. So even that, these can be used to screen patients who should have TB and obviously maybe even at the initiation of TB. So you have further tests. And again, this is also not diagnostics, it's just. This is just to look at the algorithm for that. Next slide. So world over, and even in Africa now, we are beginning to see the data that STIs are becoming common and the prevalence is increasing. So the new guidelines, they do incorporate some STI portion to see how can we track these better, especially for those very, very high risk individuals. So the Ministry of Health has generally revised also the STI guidelines. I think a copy will be printed soon, but that work was done for part of that. And we've kind of incorporated some of the STI recommendations in the HIV guidelines. But the most important one is to remember that those who have STI, that the higher risk of acquisition of HIV, and especially among key populations, including those who have like female sex workers and others. So some of the recommendations are the services to be given to almost everybody who comes to ART clinic. We need to be giving the STI services. This includes high-risk sexual practice. We've gone a bit, if you look at the previous smart care forms, has that, but this has not been emphasized. And the new revised smart care form, I think there's some emphasis on that. Prevention for those who have at high risk, annual periodic serological testing for asymptomatic syphilis infection can be offered to high risk populations. So even those who have previous syphilis, you can continue screening them annually, those who identify to have high risk because of that increase in risks for both HIV and of course, pregnant women, we are doing that, but this is to re-emphasize on that. So there's also some recommendations of treatment, which we need. The next slide. Yeah, on the new recommendations on the treatment of STIs you find in the guidelines. COVID and HIV, obviously, we couldn't do these guidelines to be without the elephant in the room, which is COVID. And we know that those who have HIV and severely immunosuppressed at a higher risk for adverse COVID outcomes. Recommendations for COVID vaccinations, we find that, and also just how COVID presents that is similar to TB, the so-called bi-directional screening as well. And also COVID-19 may disrupt ART care, both systems and also at individual level. As you've noticed, the guidelines, we want them to speak a little bit more to high-risk populations. We'll get more data as we move on as a program. Like I've said, the NSP has been done at the WHO level, at TOFA level. There's some work being done. How do we move forward? How do we identify where the reservoirs of the infection? So one of the populations that we are interested in is the migrant population, and for the following reasons why they must be considered special. So you'll find a guide on how to deal with them. So mostly is to protect their human rights and also their rights to receive the care. So you have a truck driver who is from Libya or wherever comes here. We are supposed to give care, the equitable health services for migrants, I think that's what we've signed to. Tailor-made HIV testing for migrant populations, especially for those in the borderlines. I think we are doing as a ministry some work in that space, but this should be a program issue and not a project. Tailor-made prevention, tailor-made treatment program, and so on. So we have to remember the rights that they have to receive treatment as they move around, and also that the treatment and tailor-made services, prevention, treatment, and testing with a special. So the takeaway points, we'll start where we were. DTG for pediatrics, transitioning without a vowel load. We need to phase out the 5 variants from our program. We've done so well, but let's just get rid of it. Darunava for second line, baseline vowel load, emphasis, a big emphasis on prevention, especially for adolescents and young women. This should be our song in the program, the delivering ring, STI screening, and also addition guidelines for migrant population. Thank you very much, Dr. Ziam.
Thank you very much, Dr. Sivile. It has been a very, very interesting presentation, setting a great tone to how we are starting the room. So I will share the 4 questions just for us to be able to revise. So network, following this powerful presentation, I'm inviting you yet again to participate in this. So according to the 2022 Zambia Consolidated Guidelines, which of the following is true concerning viral load testing to transition people living with HIV from TLE to TLD? Is it A, viral load testing is required to avoid monoswitching of ARVs? B, viral load testing is required because drug resistance to NRTIs is common in Zambia. Viral load testing is not required because fading NRTI backbone is equally effective when used with DTG. Viral load testing is not required because resistance to TDF is rare. All of the above. Which one is true? So we'll have a very few seconds to chance to hold this one so that we can move on to answer some questions. So I'll end the poll. Dr. Sivile, would you care to run us through this particular poll question?
Thank you, Dr. Ziambo. Yeah, so viral load testing is required. That's A, to avoid monoswitching of ARVs. So this is what we thought all along. And now we have evidence, partially it's because we have stronger drugs, that you can actually use, you can do this monoswitch, as you would call it, whether when there's a failing NRT backbone, you can recycle it and give a DTG. DTG will be the only new molecule, but it seems to hold and it seems to work. So this is a new evidence, and we have to take the evidence as it comes as scientists. So, and like I've said, it's not one trial. The trial that we've done here in Europe, in America, in West Africa, the conclusion is the same. Viral load testing is required because drug resistance to NRT is common in Zambia. We know that it is common. Pre-treatment 8%, about 50%, 60% after failure. But still, we know that even if the NRTIs, there's resistance, if you add DTG, it still works. That's the evidence. The evidence is the way it is. So C is the correct answer, because we know that even if the NRTI, the TDF and lamivudine, even if they are failing, we know that if you add DTG there, if the regimen will be strong enough. First, we don't know much about longevity, but strong regimen, and this is recommended. And really, it's true that we don't require the testing, but it's not because TDF resistance is rare. So it's quite high still, even at 8% is a big. And none of the above not to correct. So the correct answer is C.
Thank you very much. Very, very clear information there. So we check out for 2. Network, you can give it a go. According to the 2022 Zambia Consolidated Guidelines, which of the following is not true concerning the use of efavirenz according to these guidelines? Which of the following is not true? Efavirenz should not be used except in exceptional circumstances. Patients initiating ART can be offered efavirenz. Patients with side effects to DTG can be prescribed efavirenz. Patients who refuse to be transitioned to DTG must be continued on efavirenz with continuous counseling. Which one of the following is not true? Okay. Would you like?
Yes, so everybody, most of the people, 73% is it, they pick D and they are correct. So because of the high resistance, 3.2, pre-treatment resistance. And after treatment, someone who fails with a high vowel load, resistance to NRTI, to efavirenz was somewhere in the 80s, 80%. It's very high, very, very high. So we are saying only in exception circumstances and should not be used, should not be offered at initiation. It's not, previously we used to say a preferred regimen and an alternative. It's not even like an alternative. It's an exception when you don't have anything else. That's the language you want to adopt. Drug of choice, theory, for instance, unless you can.
Thank you very much. The final poll question. I think this is on the adolescents.
Yes.
I think this one was very, very straightforward. Most of people were actually comfortable. Maybe just an emphasis on this one.
Yes, an emphasis is we know where the problem is right now. You can't, previously you'd be looking like in the haystack, looking for a needle, you don't know where it is. Now you actually know where the problem is. And let's go in and solve it.
Exactly. I've got some adolescent people in the hub here. So they're just agreeing with us. Yes, not. Okay, thank you very much, Dr. Sivile, for that wonderful presentation. I'm sure the network is very, very pleased. And we have an attendance of way above 600. Thank you, network, for joining us. I think it shows how you value this session that we're having. So we are going to just run through some questions and just to clarify. So if there are any people who got questions, clarifications to make, please, you may raise your hand and then you can unmute. We will let you to unmute and then can make a comment or question, clarification. So as I search through the chat, maybe there are any hands. Satunda? So there's a hand. Okay, Dr. Zimba, go ahead. And then we can have Jackson.
Dr. Sivile, good afternoon. My question is on the DPVR ring, the 30% efficacious. Should we be going out there announcing that we should be using it when we are saying 7 out of 10 people can get infected? should we not even be mentioning it at all? Because when we go out there and mentioning it, we're telling people to go and have unprotected sex, who have the same backlash with the U equal to U. Thank you.
Very interesting questions, Dr. Zimmer. So Dr. Sivile, hang on, as we hear from Jackson Wewa and Victor.
Yes, Doc, good afternoon on this wonderful presentation. It's good to note that you are making a very wonderful progress. I wanted to find out, is the Tabavirin available, the vaginal ring, and when is it going to be available in Zambia?
Thank you very much, Mr. Jackson. There's one asking for availability. The other one is wondering whether we should be going out to preach. Very interesting. Victor? Victor, I've seen you raise your hand.
Yes,
Would you
my
like
question.
to make a comment?
Yeah, it's not necessarily a question. Just wanted a repetition of a recap of the clinical indications for doing a baseline VL.
Sorry, Victor, we didn't hear. You were saying you want to clarify the indications for
doing a
baseline
baseline
arrow
VL.
load.
Yes, clinical.
Clinical
Yes.
Oh, utility. Clinical utility.
Clinical utility.
Yes. Okay, so we've had the three concerns raised. Then we can ask Dr. Sivile to give a response.
Thank you. And those are very good questions. Just shows that it's clear. Presentation is clear. Yeah, so Dr. Zimba, obviously, I don't think it's wise to preach it that way, that we are giving, the way you are putting it, giving you this, it's only 7 out of 10, you know. But I think the understanding should be prevention is complicated, and we are offering what is called, combination preventive HIV prevention packaging. So in that there is condoms, in that there is, PrEP, and a lot of other things that you can give as a package. But that slide, it was a controversial issue, as you know. This ring, the studies were approved sometime, were done some time back. So the evidence has there. It has taken long for everybody to be convinced to say, is this the right path to do? But the motivation has been that there are some circumstances that becomes the right thing to do. Obviously, if someone can take oral PrEP, let them be on oral PrEP. But if there's circumstances they can't be on oral PrEP for various reasons that we've mentioned, let them have that as opposed to having nothing. I think that should be clear. So it's for a specific populations, again, a high-risk population. So how it will perform in a high-risk population will be a bit different from how it will perform in the general population, because of the incidence is high and the value that you get will be a bit higher because of just that selection. So indeed, I agree with you. First, the message must be clear, but equally, the selection of these candidates must be very, very clear. Otherwise, we run into a big disaster as a program. And so this is the message. Let us select the patients properly. And that slides where they should be counseled, and patients should be told that you only get this if you don't want to get that. This is like a second option. We want patients to be on oral PrEP and compliant with oral PrEP, because Oral prep, someone is compliant, the efficacy is above 90%. That's what we want. But if you can't get cheese, as they say, you can use the butter or the margarine. Second question, availability of the ring. It will be available a few quantities. I think they are on the way. So the funding, the ordering, all that thing was done, not yet in council. Baseline vowel load. So I think we're just giving the reasons why it's been. First reason is to detect silent transfer. Second, we are using it in recents already. Third reason is to give some quality assurance to our testing HIV diagnosis itself, though it's not used for diagnosis. The third reason is clinical utility. Clinical utility meaning that there are patients who will come with a very high vowel load of say 800,000. You do a vowel load at, you find that this vowel load is 20,000, for instance. We don't want people to start saying, well, this is failing, ESC, and so on. So you start doing those log drops and so on. You know, this person had an initial very high vowel load, and they are still dropping. So you can compare. So there's utility in that sense. Thank you, Dr.
So yeah, just as a follow-up, there's Martin Mamba from Mamba here asking, how do we improve the retention but with regard to silent transfers using less than viral load? But I think a more detailed presentation will come on this particular subject. We have actually put in the curriculum. Maybe you wanted to speak?
Yes, as you said, we will have probably a more detail because we know the implementation questions that come with this. But really, the benefit is you'll be able to detect the silent transfer and who's not. There are better things to use, like if you can use metabolites, metabolite. This is like an expensive solution to a very easy problem because but it's because we've done very badly with counseling, telling these patients, like patients are moving all over the show and we don't know what's going on. And really just to mention that the recommendation of baseline vowel load might not be permanent. We think it should go on maybe for 2-3 years. Looking at the problems that we have now, like I've said, it's a very expensive solution for a problem that we should have other solutions. But it is what it is. This is where we are, and these are the tools that are available. So we need to identify those who have who are silent transfers and try and reconcile the data, put them in line. That is the thought. And of course, there are all the other benefits, like I've said. Another problem of just our diagnostics, well, for some of you who might be aware, there's a recommendations by WHO that our HIV testing say should have a third test. We thought we shouldn't go that way as a guidelines team. I think there are over 30 people involved in the guidelines, so it's not me saying this. So partners and so on, most of your organizations were represented. And so since we don't have that third test as recommended for HIV testing, we've picked this to kind of have like a surrogate third test. And I must again clarify that the baseline vowel load is for all HIV diagnosis, new diagnosis, all of them. So it's not for selected, it's not for districts that are doing recents or provinces that are doing recents, everywhere where you have a new patient. Once someone is diagnosed HIV, whether in the community or in the facility, at the point of initiation, we should be in the facility. At that point, when you're collecting the baseline tests like creatinine and so on, at full blood count, the vowel load should be collected. And when you are ticking the requisition form, the new requisition form, and I hope all facilities have that, you tick the baseline, that is baseline, so that there's no confusion.
Thank you very much, Dr. Sibire. You've already gone into our next presentation. The details of the details of the. Thank you. I've seen there's some questions. Some of them in the chat have already been responded to. So please, but there's one particular question saying, can the delivering ring be used in pregnancy? I think that was one of the indications. I don't know whether it can be used together with oral prep as well as the delivering ring.
Yeah, I think this question has come before. Obviously, the drugs are different. So you can't worry about overdose in drug levels, but you wonder the utility of doing it that way. It just shows that you are not clear. So if the patient can get oral prep, let them be on oral prep. If it's a depriving ring, they can be, or let them be on depriving ring. Mixing the two, it probably will make people relax. I don't have a good answer to that one. People have asked me before because there are no trials, but I think it's an implementation issue. But I think the bottom line, it shows that you haven't counseled the patient well because and understood what are the prevention needs that patient. If they can be on prep, let them be on prep.
Thank you very much. So I'm giving an opportunity to Maureen Zmara has had their hands raised for a long time. Then we'll have Peter Singogo from Police Clinic. In that order, Maureen and then Peter.
Thank you, Doctor. Good afternoon, all. Thank you, Dr. Sivile, for that great presentation. For mine, it's just to echo and commend the screening, the strengthening of STI screening, which is scaling up to all populations. But now the challenge that we have at hand is the supplies. Are we being assured that the supplies will be available? Because at the moment, even in MCH, we are not doing so well as regards syphilis screening. And then secondly, it's on treatment. Are we being assured that these will be available? Thank you.
Very important comments coming through there. Peter Singogo.
Good afternoon, Doc. And good afternoon,
thank you.
Thank you. Our question is on the dapivirine. Would like to find out if at all there are any known side effects to read. Thank you very much.
Thank you very much for those comments. Dr. Sibile, would you like to make a comment?
Yes, I'll start with the assurance. Always a very difficult question. Yeah, so the answer is a faint yes. A faint yes, Maureen, a faint yes, in the sense that unlocking resources starts with guidelines. Like we are now, you've been in the program, you know, you've seen what we've done, be it in PPT, be it in what. Once we are strong in the guidelines to say, this is what we do, we've documented, this is what we want to do, it's in policy, it's in guidelines, it's where we want to go. Then you can use that to go and lobby for resources, whether it's at the Treasury, country, Ministry of Finance, or partners, and so on. So it's building that case, and I agree with you that you're agreeing with me that we need to, I'm happy that you're agreeing with us that we need to build that case, that this is the direction we need to go, because this has, we hope that once we've done this, in the guidelines, we are all geared, systems are there, our resources can begin to be unlocked so that we start moving forward in that space. The side effects, so in the trials, there are no big notable side effects in terms of drug levels and so on. A bit of pain in the canal, you know, erosions and so on, the site issue, but not in terms of drugs themselves.
Thank you very much. There's a question here. When is pediatric DTG reaching the rural areas. This one, I think I'll pass it on to Mr. Kampamba. He's on the call, so he can speak to that one.
I almost thought you were going to answer that, Dr. Young.
And no, today I'm a facilitator.
Thank you very much.
Mr. Kampamba, just a brief update on pediatric DTG. Mr. Kampamba, can you hear?
Is he there? He's talking.
So, okay, maybe Dr. Chungu, would you like to speak to that? I know you're a member of the steering committee that's looking at the rollout for PDTG. Maybe you can speak to that as well. Dr. Chungu?
Okay, good afternoon, Dr. Zambia. Good afternoon, network. Can you hear me?
Yes, we can.
Okay, yeah. So just to say that I think on behalf of the PEDS Technical Working Group, the fraternity, it's exciting that we have DTG for pediatrics, and there's been a lot of demand for the commodity as well. So in the initial design, there are a few rural sites that were selected for the initial rollouts. And the plan is to increase access, and that depends on a few shipments that are coming in. So we have some assurances of a few of the commodity coming in. But as for now, once we get enough commodity, the plan really is to have more sites included. So this is something that I know teams are working on, the PSM team and the ministry through Mr. Kampamba's office to ensure that we have the commodity nationwidely distributed. So very soon, I think in the coming months, somewhere around March or so, February, March, we should have increased access to PDTG in the other sites. But just the response, I think, has been very overwhelming, and even the initial feedback from not only recipients of care, but from providers as well on the commodity. Thanks, Dr. Ziambo.
Thank you for that comment, Dr. Chungu. Thank you very much. I think we've actually had quite some good interactions. Are there any more questions? I've seen a hand by Maureen again. Is that an old hand, or you'd like to make a comment following Dr. Sivile's comments?
Sorry, it's an odd hand.
Oh, okay. Thank you very much. Dr. Sivile, would you like to make any concluding remarks regarding this subject that we've been talking about today?
Yeah, thanks, Dr. Ziambo. Thanks, the ECHO team, for giving the program this platform to disseminate, to start the dissemination process of these new recommendations. So the soft copies and the booklet will be available at the end of this week. We are just pending a signature from the minister, who, as you all know, is not in Osaka at the moment. And then we'll begin our trainings. We hope to do them a bit different this time, decentralized and so on. Yeah, so these are the new recommendations. But again, I'll reiterate that we have the NSP, the national one, I think from PEPFAR, also the strategic plan from WHO, which will give us a clear picture on where we want to go this year, and going forward, what are the priorities and so on. Because as a program, we draw our strength from the NSP. So we'll have some more sessions on how we've performed as the HIV program, but also what are the priorities after that, maybe. That's, I think, maybe early or mid-February to see where we are going. So otherwise, I think the attendance was fantastic. Thank you very much for finding time to be with us.
Thank you very much, Dr. Sivile. Thank you very much to all that participated in this afternoon's echo session. We look forward to seeing you next week as we look at the program performance, the indicators, and then the interpretation, and just the targets that we have as a program. So we will see you next week. Thank you very much and have a good day.